what we have, twitching, which technically we call it fasciculations. I'm sure you must have noticed, sometimes your eyelids start twitching, and you're just not able to control it, or some other part of the body.
Yeah, there are some superstitious beliefs related to
if your left eye does,
twitching
it's bad luck, right eye good luck, and all that stuff. Now, ALS is a disease where... Hello, Namaste, Assalamu Alaikum, Sat Sri Akal. Dr. Naeem Sadiq, neurologist, neuropsychiatrist, founder and director of Plexus Neuro and Stem Cell Research Center.
Welcome to the Dr. Brain STEM podcast, your portal to understanding the complexities of neurological disorders. Today with Plexus, we're focusing on the early signs, stages, and impact of ALS in part 1 of the podcast. Together, we're committed to raising awareness, enhancing knowledge, and exploring how this condition affects the daily lives of patients and their families. Guiding us through today's discussion is Ms. Kanishka, a seasoned occupational therapist with a master's in occupational therapy and the head of the Department of Rehabilitation.
So today we're going to talk about motor neuron disease. And amongst the motor neuron diseases, we will talk about the most fatal one, which is amyotrophic lateral sclerosis or ALS. So what exactly is ALS?
MND or motor neuron disease has several types. There are 7 common types, out of which the most fatal one, like you rightly mentioned, is ALS. Now, ALS is a disease where the motor neurons are affected. Now, what do you mean by this? Like, for instance, when I'm talking to you, when I chew my food, when I move my hands, when I get up, walk, or any of these voluntary motor actions which are being done are done by certain cells in our body which are known as motor neurons, right? Now, here, if you're aware of it and if you followed my other earlier podcasts, the central nervous system consists of the brain and the spinal cord. So the motor neurons which are there in the brain are known as the upper motor neuron, and the ones which are there in the spinal cord are known as the lower motor neurons. So now both of these are dying, they get damaged and they're dying at a crazy speed, because of which the muscle fibers start dying. There's death of muscles. So the bulk which you see goes, and as a result of it, there is weakness in several parts of the body, depending on which part of the body is affected. It could be either the leg, it could be the hand, or it could also be the oral structures, which will affect the speech, swallowing, or even breathing. So this is ALS.
So basically all the muscles are getting affected, and there is thinning of muscles, the loss of bulk when you say, so muscles are becoming thin, and because of that the person is losing his or her ability to function or do daily activities. Simple daily life tasks are becoming challenging.
Correct. The bulk goes, the patient shows, you can see there are hollows there. You look at the back, there's a huge hollow. There's thinning, the arms become like sticks. So the muscle fibers just keep dying on a daily basis.
Okay, so there's just bone and skin.
Yes,
left.
Exactly, bone and skin. I've had patients who are weighing 37, 38 kgs, adult patients. So it's typically bone and skin.
So over time this deterioration goes on, and the patient continues to deteriorate in terms of functions.
Yeah. And not over time, although the onset can be very slow and not even recognized, by most of not only people, even doctors. The initial symptoms may not even be recognized. But then when the patient goes into the stage 2, stage 3, then it's just zoop, it goes down and it's too late to do anything.
Okay, so when you say it goes unrecognized and even doctors are not able to, find what is this condition, then what happens? What do patients do?
Yeah, that's an interesting thing, I've always been mentioning to everybody. Now what happens here, like for instance in ALS, in MND, the person might have very subtle symptoms initially. Like for example, I'll give you an example of several of my patients whom I've seen. Initially there was just mild shoulder weakness. The person has problem, like tying or using the shampoo or brushing his hair or something. the first thing which comes in the person's mind is there's some issue with my
Shoulder
shoulder.
is not okay. Yeah.
Shoulder is not okay. And the first doctor which a person will want to go is either a GP or an ortho. And they look at the person, do this, you have some weakness, do an X-ray. Maybe there's some degeneration or maybe there's nothing. Do physiotherapy. Okay, they'll go to some physiotherapy center who'll do some IFT, ultrasound, a few things, give them same painkillers. Momentarily, the patient may feel better or it is not progressing. When after some time you see, no, the other shoulder is also gone, or he's not able to move his elbow, or he's not able to use his fingers. Okay, or there are cases where I've had cases where patients have undergone cervical surgery, spine surgery. Okay, yeah, exactly. Because especially for the weakness. Now this gentleman was in his late 50s or something, and he had weakness, and he went and the ortho did an MRI, and MRI showed, which is obvious, showed a few discs there and some amount of degeneration, and immediately the conclusion was you need a cervical surgery. It was done. But then subsequently you notice that this person is not able to swallow now. That's when they came over, and we had to do the other investigations, confirm the diagnosis and start his treatment.
So you mean to say most of your patients first see an orthopedic surgeon or a general practitioner and rarely a neurologist?
Correct. Okay. In fact, there are so many who don't even see a doctor. They just go to a physiotherapist. A physiotherapist, you can't blame anybody. They will not have, when doctors are not aware of this ALS. Now we're talking about awareness. It is such a disease which the general population does not know. And to create this awareness, I don't know if you're aware of this, the Ice Bucket Challenge, which happened about 10 years from now, 2014, and it just became viral. And I think it was around $115 million was collected in this challenge to create awareness of this very rapidly progressive disease, which can, it's between 2 to 5 years is the lifespan. The moment the onset happens, for the person to die takes only 4 to 5 years. I would call it worse than any type of cancer. Here you see you're just going down.
And it has such a predictable course.
It's a predictable course. Now I cannot. The moment the speech goes, I know. Okay, now the red light is on. Any moment things may go wrong. So it's a terrible disease. So yeah. So the awareness is not there.
So there are a lot of healthcare professionals who are not aware of this condition, and there are patients who suffer because of this, and they keep progressing from one stage to the other because they've not got a diagnosis.
Exactly.
So is there a diagnostic criteria, or how is it typically diagnosed?
Well, that's again a very interesting question, because the way it presents, it is difficult for people to do that. The doctors to diagnose as to this is MND. Right. Now in 1994, we had the EEC, ALS Corneal Association, who came up with criteria where MND now can affect different regions. Like for instance, you have the limbs. You have the upper limbs, the lower limbs, and you have the oral cavity, the bulbar, which we call, which includes speech, swallowing, and breathing. Now, it could be definite, it is if there are 3 regions which are affected. Okay. Like say for instance, your upper limb is affected, lower limb is affected, and speech is also gone, then it is definite ALS. It could be possible if there is 1 region affected, 2 regions affected, and it could be probable, and then we have one more where it is probable with a lab diagnosis.
Right.
So this is a classificatory system just to make life easier. But then the lab investigations which are done, which will clinch the diagnosis of ALS, is the electromyography or the needle EMG. This is extremely important. But along with that, There are other investigations we also do, like for example the nerve conduction studies to rule out other neuropathies. Okay, because there are a lot of patients I have seen who have been diagnosed as neuropathy whereas they actually had ALS. Okay, so nerve conduction studies are done, MRIs are done, and we also do certain antibody tests, to rule out other immune-related disorders.
Okay, so MRIs, do they help?
To rule out some other diseases.
Okay, not to
confirm,
diagnose
no.
ALS.
ALS, the diagnostic test, if you want, it's a clinical diagnosis, the way it progresses, the way it affects. If you are in doubt and you want confirmation, it is a needle EMG, where the doctor puts the needle in different parts of the muscles and records the waves, and we have different technical terms for that. The activity of the muscles, and there are a lot of technical details, based on which the neurologist will be able to say, okay, yes, this person has a nerve degeneration going on, it's a neuronal pattern which is there, and it could most probably be a motor neuron disease. With the clinical picture of weakness in the muscles, wasting, wasting by in the sense wasting where you start losing the muscle bulk, the thinning of muscles, all put together, it's ALS, confirmed it.
So what are the earlier signs and symptoms, which patients come up with for the first signs and symptoms seen in ALS?
Okay, like I was mentioning initially, now ALS affects different parts of the body. You could either have limbs or you could have the bulb, So now 70% of patients have onset in the limbs. Now in the limbs, it could be weakness, very mild weakness use of the fingers. Person is not able to, type the way he was typing or do the fine. There is a very, very mild weakness or mild grip weakness, or it could be weakness in the leg. He's not able to walk as smoothly as possible. There are some patients who may not have weakness. Initially, they may present with what we have, twitching, which technically we call it fasciculations. I'm sure you must have noticed, sometimes your eyelids start twitching, and you're just not able to control it, or some other part of the body.
Yeah, there are some superstitious beliefs related to
if your left eye does, it's
and
bad luck, right eye good luck, and all that stuff. Yeah,
that could be ALS.
Yeah, exactly. Yeah. Now here, both the eyes are bad luck, either left or right. Not that now everybody who has a twitch will start coming and saying, am I having we have about tremors. No, it's not that. It's not just occasional twitching. Twitching which is persistent, continuous, and it is in several parts of the body. Sometimes it could
limbs.
be in your shoulder, sometimes in your abdomen, sometimes in your calf, sometimes in twitching which is persistent. You can have cramps. There are some people who have had their initial onset was just cramps, nothing, and cramps which you
painful cramps,
when you have done an extra mile of run than your usual, or some extra walking, intense workout, dehydration, extra heat, and you find a cramp. Or I know if you have experienced this in the night, suddenly you wake up and
the calf,
your calf is gone, and you squeeze and you scream out literally. So these cramps which are persistent, again, let me mention that word, persistent. Occasionally all of us get, twitches, all of us get.
Like every day.
This is there every day, and it keeps happening. So mild weakness in either the hands or the legs. It could be just twitches. It could be cramps, or some patients just have increased tone where legs have become stiff. They're not able to, it's like as if the limbs are like two logs, they're walking, something like that.
So much tightness.
Exactly. So this could be the initial signs in the limb onset ALS. Now when you come to a bulbar onset, even this is very tricky. I've had so many people that you could just have that choking, while you're, when you're eating your food, somebody cracks a joke and you want to laugh and suddenly you choke. It happens once in a way, fine. But here, the choking becomes a little more common almost every day, or maybe 2-3 times a day. That could be the initial sign. Okay.
So food getting stuck.
Food getting stuck, you're unable to swallow.
Right.
While you're, that's the reason you choke, so when the food gets stuck. Or mild hoarseness in your voice. The voice is not as smooth, as fluent as it was earlier, and it's persistent.
And it's not related to cough.
Not related to cough, not related to weather, not related to what you
Common
drank
cold.
last night.
Yeah.
Yeah, so, and it's there. See, now for instance, now, you've had a heavy party previous night, and next morning the voice changes. Okay, well, it remains till the afternoon and then it goes. Or you've had you're not used to having a very sour or cold drink, then your voice changes. Or if you're having a throat infection, it changes. But then 2 days, 3 days, things become all right. But here it is persistent over days, and there is nothing in particular causing it. Okay, and so I mentioned about the choking, coughing while eating. 2, change in the quality of your voice. Or 3, breathing. Normally the activity which you were doing, now you find difficult to breathe.
Suddenly you're breathless.
You're breathless. You were walking the same distance. Park your car and then go to the lift as usual. But now, for no reason, you're all right. You don't have fever. You don't have any exertion. The climate is okay. Keeping all the variables the same, you find difficulty breathing, and regularly. It's not that just one off day it happened and no, it is persistent. So any of these need attention immediately. Do not take it for granted. I've had patients who argue, no, it keeps happening. It happens to me also, so it's happening to him. Maybe no. Just get yourself checked up. Thoroughly do an EMG, everything, confirm, rule out it's not this, then enjoy your life. Okay, if it is, then it's time to intervene immediately. So these could be the early signs. Some of them are very insignificant. Weakness, cramps, twitches, hoarseness of voice, choking, and breathing difficulty.
So what are the stages of ALS like? If you can tell us more about each stage and how does it progress in every stage?
Right. First of all, ALS does not have a predictable course. It is not that it's going to stay in one state for so many days or weeks and months and then go. No. It can progress from one stage to the other or to the final stage within a month, or it may go on for years together. The initial stage, like I was mentioning earlier, will be very subtle. Now, if it is the limb onset, and if the upper limb is affected, the hands, you may have issues in gripping, which is the commonest thing which people have come to me and said, they're unable to grip, or when they're riding a bike, using those clutch and those things which are there, difficulty using that. Writing, okay, tying shoelaces, holding a brush, that grip is lost. This could be the initial, if it is when it comes to the hands, or the shoulder, mild weakness using, brushing your hair or using shampoo. Now when it comes to the lower limbs, or the legs, it could be, wearing your footwear, especially if it's a slide or, a footwear where you need a toe grip, they might have weakness there. Or since the movement of the foot might get affected, they might start tripping while walking. They're not able to get the balance which they were getting earlier. Now, if the onset is in the bulbar region, here we have three things. One, there could be mild hoarseness of the voice or change in the quality of speech, where a person, a stranger has to ask, what was that, and they're not able to understand clearly. There might be episodes of choking, or the food getting stuck in the throat while they are eating. or it may also cause difficulty in breathing, where they find shortness of breath while doing their normal day-to-day chores. So this is the initial stage of ALS.
So the early stages are characterized by difficulty in speaking, moving, breathing, and eating.
Correct.
And how are the early stages, different? Are they different for each patient? It's a different manifestation, or it's a very predictable course that everybody goes through these 4 things in their early stages?
Not necessarily. It is not at all predictable. It is not predictable at all. Like I was mentioning, somebody might have mild weakness in the hand and suddenly go into, a respiratory arrest. It is not predictable. It may progress from stage 1 to 2 and 3, or straight away the person might go, from mild weakness initially to a complete bulbar palsy. So it's not at all predictable. But by and large, if you take, after the initial stage, which I was talking earlier, a patient progresses on to the middle stage. Okay, so in the middle, if you're talking about stages that way, so the middle stage consists of a little more profound weakness than it was initially. Initially, it was just mild weakness, but still the person is functional. He's attending his work, he's doing all his chores, although with mild difficulty. But in the middle stage, there is more weakness, and the patient will start losing muscles. There'll be thinning. You can find hollows. In fact, patients send me their videos of the hand, where you can just see those huge hollows there. So there'll be wasting of the muscles. Then the speech becomes much more difficult, where people are just unable to understand what they are talking. And because of the weakness in this, patients, a lot of them have what we call as drooling, because the lip closure becomes weaker. They're unable to swallow, and then even the normally, because we keep swallowing our saliva, nothing gets stuck here. But patients complain, they're not able to clear the throat. Something keeps getting stuck, and there are people who have to either use a suction, or people, just clear the throat using a finger. So the upper limb, the throat, the breathing might become much more difficult. They are unable to take a few steps, and if it affects the legs, then difficulty in walking. They have to either drag their feet or use help of 2 people and walk with the help of the hip rather than the legs. So this is, and then the spasticity becomes much more profound in the middle stage, and the twitches become a lot. In fact, most of the patients who come to me are more bothered about they call it vibration, okay, in the technical words. So the entire body is vibrating, and it is an uncomfortable feeling. So that's how typical middle stage goes. But then we cannot say who will stay in which stage for how long.
And there's no duration as well.
There is no duration, absolutely no duration. Yeah, and then we go into the late stage, where it's the further progression and deterioration in the condition of the patient. Now here the most remarkable thing is, most of the people at this stage would have gone into either a nasogastric tube, where the tube feeding starts, or where you have a PEG tube, where there's a tube inserted in the stomach and the feeding starts from there. When it comes to the swallowing, and when it comes to breathing, they've already gone into assisted breathing, either a BiPAP or a CPAP, or maybe a ventilator also. So, and this is about the bulbar, and the weakness is very profound, where they're unable to move around, they're wheelchair bound, or they are bedridden. That is the late stage. And even at this stage, if treatment is sought and patient is given proper care and treatment, there are maybe there might be some hope of prolonging the person's life, giving him some kind of quality. But then if it's not done, or if the patient progresses to the end stage, the final stage, where it's mainly palliative care, taking care of the patient's needs, managing the vital functions, and keeping the patient comfortable. That would be the end stage, where he's on ventilator, and once a patient enters ventilator, it becomes very, very difficult for the patient to be weaned off because of the severe respiratory distress and the weakness in the respiratory muscles. So that's how generally the stage ends. But like I was mentioning, there is no predictable course. I've had patients who have lived for 30 years. I've had patients who have collapsed within 30 days. Okay, and talking about, I'm sure you must have heard about Stephen Hawking, who lived for more than 50 years. He was diagnosed at 21 and he died, I think, at the age of 76. So there's nothing you can predict.
So now that we're talking about such a fatal disease and such a horrible disease, are there any environmental factors, any risk factors that have an association with ALS?
Yeah, I wish, there was something specific, there was something known. Unfortunately, nothing is definite here. But then, yes, smoking, okay, my favorite.
Always.
Yeah, always has, is linked with greater risk for having MND or ALS. Then the other one where there's a lot of work going on and a lot of work which has been published so far is some chemicals, especially people who are exposed to lead in some of the industries. There they have, they are more prone to this disease. Now, there's still a lot of work to be done here to establish exactly, if this is, but it could be a coincidental or it could be aggravating, we don't know. But then yes, of all the things, one is smoking, second one is certain toxins such as lead.
Yeah, so is there a role of nutrition in managing ALS? Are there any dietary recommendations? Is there something that can be done to prolong or prevent this deterioration?
Yes. In fact, all my patients, at the end of the program, I keep one separate session of 45 minutes to 1 hour where I talk about this. It is extremely important. It's logical. Number one, it is a rapidly progressive disease where you're losing your muscles like mad. You need to replenish that. So you need not the normal, little better, more healthier option in nutrition to regain that. 2, your weakness is progressing, by the day. So you need enough, fuel in your body to maintain whatever little you can do. 3, your immunity starts keep going down. You need enough nutrition to combat and at least try to put up a proper fight. A brave front, let's fight a little. Okay, so nutrition is extremely important here, and it's vital, and plus, when somebody is seeing every day I'm deteriorating, I've had people in such high profiles. Suddenly they seek every day, I'm losing. So the depression also sets in. That also adds on to their poor appetite and increased weakness. So even there, a proper nutrition is extremely important.
So what about people who cannot eat? Like you've been mentioning right from the beginning that it affects eating, it affects swallowing, people start choking. So what about somebody who is just not able to eat?
Yeah. Okay, see, you're not able to now. What's the purpose of your mouth? Okay, so the food goes inside and gives you the nutrition, to put it in a very mechanical way. I'm sorry.
What about taste?
Yeah, exactly. Okay, so that's why I mentioned putting it in a very mechanical way. Taste is only to enjoy, right? So here, in these people, the first thing what we need to do is the moment there is some problem in swallowing, immediately we have to go into alternate ways, and The best one which I recommend, which all doctors all over recommend, is a PEG tube. The Ryle's tube or the NG tube is an option, but then that is very, it's an irritant, and people cannot tolerate it for a longer time. So having a PEG tube is a very good option, a very safe option, and a very healthy option. Now here the dietary requirement can be calculated, made it into a liquid, and just keep pushing it.
Can you tell us a little more about the Ryle's tube and the PEG tube?
See, the Ryle's tube is a nasogastric tube, where from the nose to the stomach. Yeah. So a tube is inserted through the nose, it goes right inside the stomach.
Through the nose?
Through the nose. It bypasses the mouth. Okay, and you don't have the trouble of swallowing. You don't need to swallow, you just keep pushing it. It's just a direct passage right into the stomach. The biggest con of that is, there's something hanging there.
It's always there?
It's always there. It's a tube from your nose, and with a cap there and irritating the nose.
Yeah.
It's very, very difficult for anyone to bear. In fact, this causes more depression than the disease itself.
And it's seen.
It is seen. It's obvious. Everybody is looking at you.
Yeah.
With that thing hanging. And I've had patients, who, there was a the moment he enters my room, he would say, remove it. He just wanted it to be removed, but that was a safe option for him. But then what is more preferable is a PEG tube where it's not through the nose, it's an entry directly into the stomach. Okay. So where it's not seen, it's concealed, and the food, in a liquid form is injected directly into your stomach. That's much simpler, much safer, and I strongly recommend. And I don't have the exact data to say, but from my patients, whoever has gone in for this have survived for a longer time. For one main reason, they're getting enough food, enough fuel, to run. So it's that's something which every patient, the moment it starts, they should go for it. And then you're talking about the dietary things. So the quality of food is also very important here. The patient should have one, of course, very balanced, a diet, but then the protein intake should be huge. Okay, and then yes, with the right amount of cereals and right amount of vegetables and fruits. And here we also recommend, fruits and vegetables which have a lot of color, assuming they have a lot of micronutrients. So these patients need things from all over. So food rich in protein and a lot of micronutrients, plus the cereals and the vegetables, etc. in the right combination is needed.
Right. So just out of curiosity, I want to know this. How is the response when you suggest a Ryle's tube or say a PEG tube to somebody?
Opposition. They hate it.
Yes.
They hate it.
Yeah.
Okay, they hate it. I found it very uncomfortable to
talk about it.
Yeah, to explain to them, because for a patient it looks like that means I'm approaching my end.
Yeah.
That means I don't have any hope. In fact, last week, I had a patient for whom I insisted you go in for that. He said, no sir, we will wait for 1 more month, sir. Maybe she will improve a little, sir. It's, I don't know.
So what is this? Why this? Why they do not want to get a tube and get food? And they don't want to have food through a tube. They want it only through the mouth, or they don't want to eat at all.
Yeah, no, that's that. It's not that they don't want to eat. See, what I have seen is people are more fascinated by the taste. Taking it by the mouth, not the nutrition. Okay, now even in my earlier podcast, I've spoken about this. Just digressing a little from where we are. Comparing healthy food versus unhealthy food, what is tasty and what is not so very tasty. So taste is something which is extremely important, in all living beings. Okay, so they prefer to have it. Okay, in fact, to maintain that, what I have been doing is I ask them to have a PEG tube, but then have it just a little bit, just put it on your tongue, put it on the lip, just you feel okay, this is how things are. But then yes, try to. It is a very
Very sad,
very
but
sad, very
it's a
depressing,
fact. Yeah.
depressing scenario. But it's a fact, and we need to fight. And this is one way by which you can try to fight. That's the reason why I insist on going on for a peg tube, and keep your nutrition strong.
Yeah, give priority to nutrition over taste.
Over taste, because you're going to live longer to taste more. Looking in a positive way.
So after we have spoken so much about managing nutrition, since ALS affects eating and swallowing, now there's another aspect which is breathing, which gets affected. So what is the importance of managing respiratory health in ALS?
Extremely important. In fact, in my practice, even if the patient comes with weakness of just one hand and one leg, I give more emphasis on his respiration than his hand, because he can survive with one hand. Without both hands he can survive, but without breathing you cannot survive. As simple as that. So breathing is very, very important. Number one, simple reason, to prolong your life. You breathe, you're alive. You don't breathe, you're dead. Okay, so as simple as that. Two, to carry out your day-to-day functioning. Like for example, even if there is weakness, now I want to strengthen this, I want to do some kind of therapy, I need that breath support, just like I need the nutrition, the fuel from here, I need the oxygen from there. So 2. 3, to increase my immune status, I need that. So breathing is extremely important to see to it. Number one, you can prolong your life. 2, you can combat, you can fight, and you can regain whatever strength you are losing, or you may lose subsequently. So it is very important, and we have to give, even if there's no weakness. Okay, even if the breathing has not got affected, I insist on all the patients can maintain your breathing very well.
Because eventually it will get affected.
It will get affected. By doing this, you're just, you're preparing yourself. You're increasing, you're having more soldiers on the border. So that if something happens, I'm I'm ahead of them, so I can combat, I can fight better.
So what interventions are most effective in managing respiratory health?
Now here, if you start, bottom up, the first one would be proper, breathing exercises, which the patient should be trained in, doing, we have a specific breathing exercise pattern for bulbar palsies, for ALS, for MNDs, which I emphasize. It's become my pet peeve now. People do not understand. It is not just rapid breathing. No, you will exhaust yourself more. There's a specific way by which you train your lungs and your diaphragm and all your accessory muscles to breathe. So first thing which is very important in ALS is to teach the patient the proper way of breathing to increase the respiratory support. 2, to have the airway clear, use of bronchodilators, use of nebulizers, which will help a lot to keep the throat clear so that it eases the breathing. Then 3, it could be manual technique, just as chest physio, where we do that. We train the patients and the patient's relatives as to how do you do that, and help ease, relieve the congestion in the chest, so that helps in breathing. Now these could be, and in the exercises, we use a lot of assisted devices, to train the patient how to improve the breathing pattern. But despite all this, despite doing this, there are patients who are, for months and years they're able to do this, but then there comes a time, especially for me, when I'm, sometimes I see this patient did so well for 6 years, 7 years, 8 years, and now suddenly, no. Now he's not able to. Then we go in for the assisted ventilation. Okay. Now in assisted ventilation, the commonest ones are either the CPAP or the BiPAP, where it's the machine assists in breathing, which is unlike a ventilator. The patient has to use it intermittently. Most of the people, I recommend they use it in the night or whenever they are at distress. But sometimes if the disease progresses, they may have to use it for a longer time. Okay, and yes, of course, if all these do not work and the patient goes into the final stage, then he needs a mechanical ventilator.
Okay. Personally, I've also come across patients doing a lot of yoga and pranayama. So, what is your opinion on this?
Well, yoga is good. Okay, yoga is good. Pranayama is good. But then for these people, it's not good. See, anything, for instance.
So, it's for normals, you mean?
It's for normal people. It's for normal people. Like for instance, running is very good. No, I cannot ask a patient with muscular dystrophy to run. Okay, it's not for him. It's for a normal person, right? So similarly, yoga is a very good, alternate form of medicine or alternate way of healing. But patients with ALS, it's not good. In fact, even the physiotherapy which is done for patients with ALS is different from the conventional physiotherapy, which, I'll talk I'll explain about it sometime later. Well, guys, that was, the description of ALS, the causes, the progression, how it, progresses from stage 1 to stage 2. So this is Dr. Naeem from my channel, Dr. Brainstem, signing off. But then, before I sign off, want to inform you that yes, this disease is alarming. This disease is, not a very happy disease. It progresses so fast. But then, is there any treatment for that? Is there some way we can manage? Yes, I am going to come back in my next podcast and give you all the details about the treatment, management, what do the caregivers need to know, and what are the recent advances and how the world is progressing towards finding a solution for this very, very, very fatal and rapidly progressive disease. Till then, bye-bye.